Good morning. Can you see my screen?
Yes, wonderful.
Perfect. So first, I would like to acknowledge all the team involved, especially Dr. Akinduro for guiding me and helping me putting this presentation together. The Dr. Quiñones, Dr. Gentov from the Pathology department, and our neuroradiologist. So this is a 54-year-old female who started having progressive neck pain at the end of last year by December in 2021. She referred cervical myelopathy in the distal part of her left shoulder and arm. This was intermittent, and she also referred some difficulty to swallow. Patient denied any bowel or bladder symptoms. She tried multiple conservative management strategies, but didn't help with the relief of her pain. On the physical examination, she was oriented, alert, and on the upper extremity, left upper extremity, she presented weakness, about 4 out of 5, as well as the triceps and grip. And in the right upper extremity, only in the deltoid, and the rest was intact. The reflexes was pathologic reflexes, inclinus bilaterally brisk, and the cranial nerves were grossly intact, and the sensory and gait was within normal. So for past medical history and past surgical history, patient didn't have any relevant history. She was currently in naproxen or naproxen metocarvamol, but this didn't help with her relief of pain. Now we have the preoperative MRIs. First, we have the sagittal. Here we have the sagittal T2 and T1 postgadolinium, and first of all, it looks like a cervical orthotic curvature, and we can see a well-defined extramedullary hyperintense lesion within the spinal canal at the level of C5, with a compression at the level of C5 and C6. And we can see also some degenerative changes. Dr. Vishal Patel, I don't know if you would like to comment on this.
Sure, yeah. So we're showing again a sagittal T2 weighted image and a post-con T1 weighted image. And as you said, there's a well delineated mass there at the dorsal aspect of the C5 vertebra, causing some compression of the cord, and extra medullary is one of the descriptors that we use. We typically will throw these spinal masses into one of 3 bins. The intramedullary lesions, like the astrocytomas, ependymomas, hemangioblastomas, the intradural extramedullary lesions, which is what it looks like this would be, where you have the most common ones, meningioma, nerve sheath tumors, and possibly metastases, and then you have extradural or epidural lesions, which are often bone or disc-related things, or metastases.
Correct. And here also we have the axial T2 and the T1 postgadolinium, and we can see again how the lesion is extramedullary round and is very eccentric, and in here again we can see the lesion in the T1 postgadoline.
Yeah,
Yeah.
thank you. So go ahead. I was just
Oh,
gonna
no, I was
say,
just gonna mention that there's this historical artifact. I don't think people use it much anymore because it's not very reliable. But there used to be something called the Ginkgo leaf sign that related to this anchoring of the cord by the denticulate ligament as the extra medullary mass was pushing it over to the side, and that was thought to provide some sensitivity for differentiating schwannoma from a meningioma. But I think it was ultimately found, you kind of see it here, but it was ultimately found to be not particularly discriminatory as far as differentiating those two entities.
that's really cool. Actually, I haven't heard of that. I'd love to hear more about that. You said that that's the attachment to the dentate. I'm sorry, I didn't understand that completely. Could you explain that a little more? Hello?
Sorry, I muted myself by accident. Yeah, absolutely. So the mass will displace the spinal cord off to one side or the other, depending on its location. And then a lot of times you'll see sort of a small a tethering of the thecal sac, and it was thought to represent the denticulate ligament, or the visualization of the denticulate ligament by MRI. And I think the initial report said that favored a meningioma rather than a schwannoma, but subsequently I think people looked at it further and found that the sensitivity of that was quite low, somewhere around 50%, which is basically useless.
Yeah, nice. That's yeah, I just haven't heard of that the sign in the way that you described it. But yeah, I mean one of the main most important points when looking at this imaging, when planning, for surgery is kind of how the tumor appears to be draped over, or sorry, the spinal cord appears to be draped over the tumor. And that's something you have to factor in when considering how to approach it. Some would even say consider approaching it ventrally with a corpectomy, which I think is a lot. But most likely you're going to go for a posterior approach here, and then the only question becomes if you can do just a simple laminectomy, or if you need to take part of the facet joint to be able to avoid the spinal cord. And I think initially, whenever she was seen and surgical planning was discussed, a laminectomy was initially the plan. And then, I looked at it, and then, we discussed it in one of the conferences. And, the safest way to that we discussed to address this for her was to, go ahead and do a short segment fusion just with 5 and 6, and then, kind of go lateral and take part of the facet joint to where you would avoid having to try to push that spinal cord over. Yes, when you get in there, if you identify the dentate ligament, the spinal cord maybe could be mobilized a little bit easier. But we thought that the safest thing for her would be to just go ahead and plan to take a little bit more to take a little bit more lateral trajectory by removing part of the facet joint. All right, Andrew, you can probably keep going unless anyone has any other comments about that.
Okay, thank you so much for your input, Dr. Patel, Shal Patel, and Dr. Akinduro. So as mentioned, given the radiographical characteristics, and on the top of our differential, we will have schwannoma, which is also the most common intradural extramedullary spinal tumor, followed by meningioma and neurofibroma for differentials. Due to the tumor, the characteristics that Dr. Akinduro mentioned was very eccentric to the left, and the safest approach was to resect the tumor, and it was decided to do it more lateral, removing part of the facet joint, since the spinal cord was apparently trapped over the tumor itself. And well, the goals of the surgery was to have a tissue for diagnosis, maximal safe resection, and to avoid neurological deficit. So C5, C6 posterior cervical laminectomy with C5, C6 instrumented fusion with lateral mass screws was planned. And here, the patient was taken to the OR and placed in a prone position. The superostal dissection was performed. The location of the C5 and C6 were confirmed by X-rays, and MEPs and SSCPs were obtained at baseline. So then Dr. Akinduro started working on the drilling of the C5 and C6 facet joints with the drill course, and then also he started the placement of the working on the laminectomy.
I could add some comments here. Yeah, we didn't do the laminectomy yet. Here, we just placed the screws. You typically want to place your screws before doing the lami, so you're not, placing screws over an exposed spinal cord. But what I was doing earlier was drilling out. Take like a smaller drill bit, and it's easier to drill the facet joint before you place the screws, just because the screw heads aren't in your way. And also, drilling out the joint helps you with your trajectory as well. I found that it's just easier to kind of visualize it whenever you go ahead and basically just follow the angle of the joint itself. And the other thing is kind of knowing the starting point for the lateral mass screws. And you want to start off by kind of imagining the lateral mass as a box, and then really the easiest, simplest way to do it is just to draw, just put a point right in the dead center of that box. Usually maybe cheat slightly more inferior and medial, but end of the day, you'll be safe if you kind of go smack dab in the middle of that, and then you're kind of aiming for the upper outer corner, kind of like I say, kind of following along the trajectory of the joint itself. And then, like you said, then we continue with our laminectomy, and we did not place the screws. So what we did is we just uh, drilled the hole for the screw, and then we tapped the screw hole, and then we left the screws out just so that they wouldn't be in the way while we're doing our tumor resection. And then, as mentioned, we took part of the facet joint off to the left, a decent amount of the facet joint off to the left, to make sure we had, kind of a little bit slightly more lateral trajectory, so we could retract the dura enough to try to avoid inadvertently hurting the spinal cord. And then the other thing here, I think we brought in the ultrasound soon, just to confirm that we had enough exposure, rostral and caudal, to our so you can see the spinal cord there. I think that ultrasound was after, because we took one in the beginning and we saw that we need a little bit more. So then we took a little bit more of the bone superiorly, and then we continued.
Yes, this is the second one. And here is the tumor was identified. More ventral. Okay. So.
And we kind of intentionally centered our durotomy centric to the left.
Yeah, and the door was open, and then the nylon was used to expose the plane. And Dr. Akinduro proceeded to identify the tumor and the dentate ligament.
Yeah, that was the dentate that we just cut there. So then you can see all the the nerve roots, the dorsal nerve roots draped over the tumor. So we identified it laterally, and then we cauterized the capsule of it. We knew we weren't going to try, we weren't planning to even consider trying to just remove it on block, just because the size of it and how close it was and compressive it was on the spinal cord. So we started with some internal debulking, and how this case goes is 100% determined by the consistency of the tumor. Remember the last one of these I did, the tumor was just a rock, and it was just painful. I had the sonopet in there, and even with the sonopet at the highest setting, it was just taking forever. Thankfully, this one was suckable, and we were able to kind of, take it out piecemeal. So there, you can see that, we found where it was attached, and it was attached by a nerve root. So obviously pointing to a schwannoma. So you saw how you always want to stimulate the nerve first. Typically, they tend to come from more sensory nerve roots, and usually by the time, there have been kind of reports of this in studies. Usually, they kind of the nerves themselves kind of lose function over time. So overwhelming majority of the time when you're removing these, the nerve that it's coming from is not going to be a functional nerve root, but there have been some case reports of them coming from functional motor nerves. Like I said, that's reportable. It's very rare, but for that reason you always want to make sure you stimulate the nerve that it's coming from before actually cutting it.
Then it was removing one piece.
And then here we're just stimulating all the nerves surrounding it just to make sure that everything else was functional.
Then after irrigation and hemostasis and cauterization of the small bleeding pedicles, then Dr. Akindura proceeds with the closure.
Not sure why the video is skipping so much, but yeah, we just closed using 6-0 Proline. Then I always get a Valsalva at the end to make sure everything is dry. And then blue glue or Duracell on top. And then once that's done, we just place the screws into everything we had already kind of tapped and drilled. And the other thing is, arthrodesis is an important thing. You're placing the hardware, but they have to fuse. So if you just place hardware without, arthrodesing, and what I mean by arthrodesing is, drilling off the cortical rim of the bone to expose the cancellous bone. Bleeding bone forms new bone. So if you don't do that and then lay some bone graft, we mostly just used her own bone that we got from the laminectomy. We stuffed it into the facet joints, and then out over the lateral masses just to form a fusion mass. And then for intradural work, we typically close the skin with like a running suture, non-absorbable.
Thank you so much for the.
Yeah. So Gabriel had Dr. Vargas had a comment, and this is actually one of the main points of discussion beforehand when we're discussing it with some of our colleagues. And I'd love to hear what other people's thoughts, because like I said initially, we weren't planning to place any screws, but just because it was and as you can see, you can't, it's hard to appreciate because you didn't really see how much of the joint we actually removed, but we did remove a decent amount of the joint, which is why we're able to retract the dura as much as we can, and we're able to, because even the whole surgery we did was off in that lateral gutter, but I think there are another point of discussion is, even if you do a unilateral facetectomy, do you always have to fuse? And that's an ongoing point of discussion, I think, and there have been some papers looking at that, but I'm interested to hear what everyone else thinks about that.
Yeah. Sometimes even if you remove a lot of facet, nothing happen. Or sometimes you can use only unilateral screws sometimes, but whatever is the experience of the people, a nice surgery, of course. But I think that sometimes the screws can interrupt your view. I don't know, or not to allow you to go so lateral. So that's my point. What do you think?
Oh, I see what you're saying. The screws being there, and that's why we didn't put the screws in beforehand. But I mean, I kind of discussed this with a couple of the spine surgeons here beforehand, and I think once again, I think it's just personal preference, and I think experience is going to be different at different institutions. But discussed with some of the spine guys here beforehand, and they suggested considering screws, and basically if we had taken all of the facet and all of the lateral mass on that side, and there was no potential to place the lateral mass screws, then yes, we would have probably just placed a unilateral screw. But we intentionally actually started, the starting point for the left-sided screws was slightly more lateral than usual for that reason, with a less lateral trajectory. But actually, Dr. Awad, who came from another institution, I'd love to hear what maybe the experience was at I think Utah for something like that.
Yeah, that was a great case. I think we generally would fuse just like you guys did. And just with the comment about putting the screws, we did the same thing. We drilled, tapped, and then we would actually use anesthesia has a bougie tube that they would use for the ETV. Those blue tubes are sterile, and one of my attendings would take them, cut them into segments, and put them as screw placeholders so that it's just easier to find your screw and always know your trajectory. Some people have really small facets and you don't want to change your angle.
Yeah.
Right before you place your screw and crack them out. So, but yeah, our general practice was if we caused a unilateral facet disruption for this type of case, we would generally fuse.
Nice, thank you. All right, I don't know if we have any other comments from anyone else about this case or any of the other ones.
Yeah, here I just want to show that it was a gross
Oh, yeah.
resection.
That's right. Continue. Sorry, we have more.
Yeah, here's just like the pre-op, and then this is the post-op. And before, it was just to show the X-ray of the posterior instrumented fusion. And then the pathology, Dr. Gentov, are you in the line?
Yes, I'm here. I'm here.
Could you please, would you like to comment on the pathology slides?
Absolutely. So for the tumor, you can see this has areas of hypercellularity in an area that has a lower cellularity. These are known as Antony A and Antony B areas. So that's something that's pretty typical of a schwannoma. And if we go to the next slide, we do have not classic, but sort of loosely arranged Verricae bodies here as well. And the other features were consistent with a chordoma, maybe not the best one to put in a textbook, but definitely consistent, and it's strongly S100 positive, thus further supporting the diagnosis.
Yeah, and on the postoperative course, the patient presented some nausea and vomiting due to probably one of her medications. And the team decided to switch her oxycodone to Norco. And then her strength improved some by the discharge. She was 4 out of 5. And the delta was mainly due to her pain. But at the discharge time of discharge, she was 4+, and then the sensory was still intact. The hemobag drain was removed on postoperative day 3, and she was discharged home on postoperative day 5.
Yeah, she did really well after surgery. Actually, she would have left a lot earlier than that. She just was having a lot of neck spasms, but she didn't want to take the spasm medications. So, I mean, the pain got better when she actually started using the meds, but really, we discharged her we actually discharged her a couple of times, a couple of days before that. And then she just had, severe, neck spasms, and come to find out she was refusing the medications because she thought the medications were causing the spasms for whatever reason. But either way, she did well. All's well that ends well.
Thank you so
It
much.
was a it was a very nice resection, Dr. Akandura. I think I read the post-op in addition to the images that were shown. Of course, showing no residual tumor. The T2 weighted images also show, importantly, that there was no injury to the cord or any cord edema. So the steps you were describing intraoperatively to protect the cord, I'm sure the patient appreciates that. It looks like a pristine cord. And then one other quick comment: the tumor, if you all remember on the preoperative images, was very T2 bright, and that's sometimes been described as predictive of the softness or the suckability of the tumor. So it was interesting to see that was indeed what you found intraoperatively.
Yeah, thank you. That's actually a point I was going to make. But yeah, this was, it was a great case, Dr. Q and myself, with, hand-to-hand combat to get it taken out, safely. So thank you all.
Thank you all.
And this is just a flyer for next Monday. We're going to have Dr. Chumakaris from Jefferson presenting on robotics and the future endovascular neurosurgery. So join us next Monday, and thank you everyone for joining. I don't know if anyone has any last minute comments. All right. We'll see you next Monday.
Thank you, everyone.
Thank you.